Assalamu alaikum. This is Salim al-shakliah. In this presentation, I am going to compare between tenecteplase and alteplase efficacy in ischemic stroke based on clinical outcomes. Sorry, based on clinical trials. This video or this presentation is produced as a course requirement for FCP 555. Stroke is defined as a clinical syndrome characterized by rapidly developing clinical symptoms and or signs of focal and at times global loss of cerebral function with symptoms lasting more than 24 hours or leading to death. According to the Department of Statistics in Malaysia, 2017, stroke is the third leading cause of mortality. There are different causes of ischemic stroke, such as the large artery atherosclerosis, penetrating artery disease, embolic, other causes, and cryptogenic. In fact, not every ischemic stroke is eligible for IV thrombolysis. There are some requirements or criteria. First, the symptom onset must be within 4.5 hours of presentation. And hemorrhage should be ruled out using NCCT or MRI. And if it is a wake-up stroke or stroke of unknown onset, IVT may be considered only if the MRI shows stroke with DWI and flare mismatch. In patients with suspected intracranial large vessel occlusion, it's reasonable to proceed with CTA. There must be no contraindications, and the sonothrombolysis as adjunctive therapy with IVT is not recommended. And thrombolysis definitely should not be delayed for aphasic patients waiting for their consent. There are some absolute contraindications. One is the pre-treatment systolic blood pressure, more than 185, or diastolic, more than 110, because it increases the risk of bleeding, so it should be corrected to aim for a blood pressure of less than 185 systolic and less than 110 for diastolic. Blood glucose should not be less than 2.7 millimole liters. And a current use of treatment dose of low molecular weight heparin within 24 hours increases the risk of bleeding. Also, unfractionated heparin in the previous 24 hours prolongs the APTT, so it increases the risk of bleeding too. In general, clotting parameters such as the APTT, INR, and direct factor XA activity should be within normal limit to limit the bleeding risk. If a patient is on dabigatran, he or she should be given either riocizumab to reverse the action of dabigatran to minimize the risk of bleeding. PT more than 15 seconds and APTT more than 40 seconds or INR more than 1.7 are absolute contraindications as they increase the risk of bleeding too. And also a platelet count of less than 100,000 microliter. Relative contraindications. This means they are not strictly prohibiting the administration of IV thrombolysis, but risk benefit should be assessed here, such as in serious injury in the previous head serious injury in the previous 3 months, stroke within 3 months, myocardial infarction within 8 weeks, GIT or UTI bleeding in the previous 21 days, Major surgery within the preceding 14 days, and prior intracranial hemorrhage of irremediable cause. Seizure also at the onset of stroke and pre-morbid MRS more than 4, peritoneal dialysis or hemodialysis, and pregnancy as well as nursing. Regimen for treatment of acute ischemic stroke with intravenous thrombolysis, 0.99 milligrams per kg up to 90 milligrams. 10% of the total dose is given as an IV bolus, and the rest, which is 90, is given as an IV infusion over 60 minutes. Tenecteplase, an alternative to alteplase, should be given when alteplase is in shortage. The New England Journal of Medicine published a trial which compared tenecteplase and alteplase efficacy before thrombectomy for ischemic stroke. The name of this trial is Extend IA-TNK, which refers to tenecteplase. The primary outcome was to evaluate if tenecteplase could achieve superior reperfusion rates and functional outcomes before thrombectomy. Regarding the methodology of this trial, it was an investigator-initiated, multi-center, prospective, randomized, open-label, and blinded outcome funded by Medtronic, which is an industry. The above mentioned characteristics of the study, other than open label and funding by Medtronic, are the strong elements of the study methods and design aspects lend credibility to the findings. However, the open label design and the sponsorship by the Medtronic industry present major limitations to this trial. This study was conducted between March 2015 and October 2017 at 12 centers in Australia and 1 in New Zealand. 202 participants were enrolled in the study, have received alteplase, and the rest received tenecteplase. The sample size, 202, was enough to detect significant differences in primary outcomes. However, the sample was limited to detect safety outcomes such as hemorrhage. Patients in this study were randomly assigned in a 1:1 ratio to receive either intravenous tenecteplase, 0.25 milligrams per kg, single bolus dose, and alteplase, 0.9 milligram per kg, infusion over 60 minutes. The primary outcome was substantial reperfusion and the absence of a retrievable thrombus. The secondary outcomes, first, the functional outcome measured using the MRS at 90 days, and the neurologic improvement using an IHSS tool score. Safety outcomes, which were measured, are mortality and symptomatic intracranial hemorrhage. As shown in the table, the outcomes, 22% of the alteplase, of the tenecteplase group experienced, experienced substantial reperfusion, and only 10% of the alteplase group experienced substantial reperfusion. The difference percentage points was 12%, so suggesting that the result is statistically significant, 0.03, the p-value. The unadjusted incidence ratio was 2.2, and the adjusted odds ratio was 2.6, suggesting that the odds of achieving substantial reperfusion with tenecteplase are 2.6 times higher than with alteplase. Regarding the functional outcomes at 90 days, tenecteplase group had significantly better functional outcomes compared to alteplase, but these differences were not statistically significant. And in terms of early neurologic improvement, tenecteplase had better excellent outcomes, but the differences were not statistically significant too. The modified ranking scale scores at 90 days in the intention to treat population was 0.2, as in the graph, for the tenecteplase, indicating better functional outcomes, and 4 to 6, between 4 and 6 for the alteplase, indicating severe disability or death. So in general, patients in the tenecteplase group had better overall functional outcomes and fewer deaths compared to alteplase group. Regarding the NIHSS, actually, there was no difference between the two groups. One limitation, or major limitation to the study, this study actually included only patients with large vessel occlusion, such as the middle cerebral artery, which represent 13% of ischemic stroke cases. So the applicability of the outcomes to patients with other types of strokes cannot be made here. Conclusion: tenecteplase was non-inferior to alteplase in restoring blood perfusion. Tenecteplase showed better overall functional outcomes than alteplase in the ordinal MRS score analysis. The other study, which compared alteplase and tenecteplase, was the ACT, aimed to compare tenecteplase with alteplase in patients with acute ischemic stroke treated within 4.5 hours of symptom onset. The primary endpoint was to evaluate if tenecteplase could achieve non-inferior or superior functional outcomes and safety compared to alteplase. It took place in Canada, where the healthcare infrastructure may be different significantly from resource-constrained environments. The difference between these two, the first mentioned one and this one, is the funding. This study was publicly funded, and this minimizes the concerns of industry bias. The study was a pragmatic, multi-center, randomized, open-label, blinded outcome assessment trial conducted in 22 centers in Canada, and 1,600 patients were included to achieve high statistical power to detect non-inferiority. The intervention was a standard protocol, just like the one before. Tenecteplase, single intravenous bolus, 0.25 milligrams per kg up to 25 milligrams. Alteplase, 0.9 milligrams per kg, 10% given as a bolus, IV bolus, and 90% given as an infusion over 60 minutes. Primary outcome was functional independence at 90 days, measured using the MRS. Secondary outcomes were symptomatic intracranial hemorrhage, mortality at 90 days, neurological improvement at 24 hours, and excellent functional outcomes. The primary outcomes, functional independence, actually 36.9% of the tenecteplase and 34.8% of the altiplase showed functional independence. The unadjusted difference in proportion was 2.1%, indicates no statistical significance between these two groups. The secondary outcomes, median actual MRS was 2. So the majority experienced moderate disability and no differences between the two groups. The EQ VAS score measured patients' self-rated health status on a scale of 0, meaning imaginable health, to 100, meaning best imaginable health. These outcomes were statistically significant between these two groups. Regarding the modified Rankin scale score, the score for altiplase was 15.6%, and for tenecteplase 15.2, so almost the same, and there is no difference between the two groups. In terms of safety or risk differences, as shown in the table, in the red zone here, the risk differences shows that tenecteplase is as safe as altiplase, with no clinically significant differences in adverse event rates. Conclusion of this study, tenecteplase is a safe, effective, and practical alternative to altiplase for acute ischemic stroke, offering significant advantages in administration without compromising outcomes. The trial results support its use in clinical practice. So my recommendation by the end of this presentation, based on the mentioned two RTCs, is that tenecteplase can be used as an alternative to altiplase in ischemic stroke. Thank you very much. This is the end of the presentation.